accountability matters, but also compassion matters as well, knowing that people can redeem themselves and come back from something like that. Wow, this is getting pretty crazy. Hi, I'm Dr. Jeff Yu, a board-certified ER doctor in the USA and Canada, and it's 5 p.m. in the Pitt. Today I'm going to be watching the Pitt Season 2, Episode 11. I'll go over what's realistic, what's not, and I'll explain all of the medical management throughout the show. Let's get to it. Okay, so they're starting the episode with the case of Roxy, where McKay is doing essentially medical assistance in dying. She's giving her a lethal dose of morphine that will, yes, it will treat her pain, but it will cause her to stop breathing and eventually cause her death. But I don't think that it's realistic that emergency physicians would actively give a medication like morphine that would cause a patient to die if they weren't already actively dying. So Roxy finally passed away, despite Dr. Robbie's many flaws that are kind of surfacing in these last few episodes. I think he still has the ability to really be empathetic and compassionate with his patients, and the fact that he didn't have to say anything and just put his hand on the shoulder of the husband, I think just shows that he is a compassionate physician at his core. I like to believe that these subtle gestures that physicians do towards the family members after, a tragic incident or a family member has died, a lot of the family members won't remember the words that you speak, but they often do remember the vibe. They remember how compassionate the person was. They remember if the physician and the care team was, just there for them emotionally. And I thought he did a good job in this scenario.
Did Adam ask you if you wanted to have sex?
Mel, I don't know if I can tell you.
Of course you can tell me, I'm your sister.
Well, it's private.
Look, it's really important that I know.
Why?
Because.
Well, I can tell Dr. Langdon because Dr. Langdon is my doctor.
Becca, just tell me.
Why are you yelling?
I'm not yelling. It's just, look, it's really important that I know. Why won't you tell me?
Dr. King, why don't you get some air?
Yeah, that's a really intense scene. So this is a really important issue that they're bringing up into the Pit. The reason that Mel is asking so many detailed questions about consent in sexual intercourse about her sister who has autism is because autism isn't necessarily an intellectual disability. Oftentimes they do co-occur, but they can occur completely independently. There are incredibly high functioning and high IQ people with autism. Essentially, it is a neurodevelopmental disorder, and people who have autism and other neurocognitive disorders and intellectual disabilities will be at higher risk of different forms of abuse. So I think that is why Mel is spending so much time actually probing into all the details of this relationship that her sister has with this older man.
I mean, who's to say he didn't take advantage of her? Maybe he'll just let it happen.
Are you Becca's legal guardian?
No, I have durable power of attorney, but we did this thing called supportive decision-making where she can make her own decisions.
There you go.
So yeah, this is a really good point. Even though Becca has a history of autism, that doesn't necessarily mean that she isn't able to be a competent decision maker, someone that is able to provide consent in the context of sexual intercourse. I totally understand Mel's perspective that she's, wants more information. If Becca actually understands the full situation and is a consenting adult, she can make her own decisions.
Adam asked you to have sex.
He didn't ask me. I asked him.
So you didn't pressure?
No.
So you wanted to have sex?
I wanted to have sex. Sex is great. We talked about sex in my mind and body class. I told my therapist too.
It's great that they're showing that all the facets of informed consent during sexual practices in the context of something like a neurodevelopmental disorder like autism. In this case, it seems like she was a consenting adult and there's no real suspicion of sexual abuse or anything like that.
My son, he's not moving.
I'll show shit.
I got a hot and unresponsive child. I need a room, Dana.
He was fine all day. I found him in the car.
Oh shit.
Pupils are sluggish but reactive. No reaction to pain.
Airway is patent with low tidal volume. Let's set up for intubation.
Heart rate is 22 in 10 seconds. That's 132.
What we have is a child that's coming in with a suspected hyperthermia. It sounds like the mother found him in the car. I'm guessing she left him in the car for a long duration of time. This would be heat stroke until proven otherwise. And if he has decreased level of consciousness, the first thing that we would think about is a seizure in the context of hyperthermia. The main priorities in managing this patient are, first of all, rapid cooling. That's usually done through a few different methods. So one is evaporative cooling with misting and fans, cold IV fluids, and the quickest and most effective way to cool someone is to put them into an ice bath to completely cool their core temperature down. You would want to secure this kid's airway as quickly as possible and give them a paralytic like rocuronium that would take all of the muscle activity away, because once you start cooling them, one of the things that you often do encounter is significant shivering, which actually prevents you from actually bringing their core temperature down. I run resuscitative simulations and film them and post them on YouTube, and we ran a very similar case of severe hyperthermia due to serotonin syndrome, and it goes through the entire management of recurrent seizures and severe hyperthermia, and you can see them in this video over here if you want to check it out sometime.
How long was he in there?
Maybe 15 minutes or 20.
And the car was just unlocked.
Oh, it's a safe neighborhood.
Okay, so Joey is asking all these probing questions, a bit in an accusatory manner. And I think that she's asking in this accusatory manner because this situation with a kid coming in with heat stroke, decreased level of consciousness, and they were found in a car is abuse until proven otherwise, because we do get scenarios where parents leave their children in cars, especially buckled in child safety seats, where they're unable to buckle themselves out. Heat stroke is absolutely terrible. Like, you essentially cook all of your organs and your brain inside your body. You can have neurologic disorders, muscle breakdown with rhabdomyolysis, which causes renal failure or kidney failure, requiring dialysis, liver failure, causes liver cirrhosis eventually. Definitely if a parent left a child in a car for a prolonged period of time while it's really hot outside and it leads to heat stroke, this is 100% something that we would get Child Protective Services involved in.
I have doses for rock and ketamine.
Almost no tone. I can do this without meds. It's easy enough to bag. Let's wait for RT.
They said that they already have ketamine and rocuronium drawn up, but because the kid has no muscle tone, he's completely flaccid, oftentimes we might actually just intubate without any paralytics on board or giving any medications. This is what we often refer to as a crash intubation, where we essentially just secure the airway as quickly as possible with no medications on board.
Temperature's this high, the muscles can lose their strength. So we're going to help him breathe with a tube.
Rectal temp is 105.5.
Heat stroke.
His core temperature, which is a rectal temperature, is extremely high, 105 degrees Fahrenheit, which is above 40 degrees Celsius. What we would typically do is keep a core temperature inside. Rectal temperatures are not the most ideal areas to keep it, because oftentimes the rectal temperature probes get stuck in feces. That will distort the temperature that we're actually reading throughout the body. The best way to keep track of someone's core temperature is by intubating them and putting an esophageal temperature probe down. So essentially it's almost like a feeding tube, but it goes down just midway down their esophagus and sits at the level of their heart. And that will keep track of the temperature that the heart is feeling, all the blood that's circulating through the heart.
Temp is down to 103.5.
On way to 98.6.
102, we take him off the ice. Otherwise, we can overshoot and cause hypothermia.
This is very realistic. If you watch that simulation video that I posted on serotonin and hyperthermia, we did the exact same protocol, putting someone in a body bag in a bath of ice. So what it is you fill the entire body bag with ice cubes, but you also mix in water so it becomes like an ice slurry, and this brings their body temperature down very, very quickly. With that temperature probe that goes into the esophagus, you'll want to make sure that the temperature is not going too low, you can overshoot your target and cause hypothermia, which can cause other issues. Hypothermia is actually much safer than hyperthermia, especially because in severe hyperthermia and heat stroke, there's a high chance of actually cooking your brain, and hypothermia, bringing the temperature below the target, actually is neuroprotective. It protects the brain. So it's not the worst case if you overshoot your target, but it is something that we typically watch for.
I just don't buy it. She lost her kid at home. Plus, she just looks guilty. Has anyone seen her cry?
People don't always respond to trauma the way you expect them to. Stay focused on the kid.
Yeah, that is really true what Dr. Robbie says. People respond to trauma and tragedy in completely different ways, and it's not for us to project our own perceptions of how people should react. Because I think once you start assuming and start placing blame on people, like you've crossed the line of where your duty as a healthcare provider begins and ends, and crossing into moral court and deciding, you know, if someone is morally right or wrong. That's not our job to do. Our job is to provide care.
There's no certainty as to how much recovery Michael will have. His response over the next 24 hours will tell. There is a chance of cognitive impairment, but also a chance of meaningful recovery.
Dude, oh God, that's so tough.
Have you ever thought about hurting yourself? Brenda, where are you going?
Oh,
Pittsburgh.
hell, dude. Jesus, man. God. Damn, bro. Okay, a lot just happened. This is crazy. Jeez. I think the guilt that parents feel when anything goes wrong with their child is so incredibly intense. Oftentimes I'll see parents who come in after their child has fallen and, you know, hits their head or sustains a laceration, and parents will often blame themselves, which is why I never try to like confront parents and place blame on them or make them feel guilty about what happened, because I just think it's like difficult enough being a parent. Man, that's a really heavy case. As a parent myself, I feel like it hits home as well. Yeah, it's just, it's crazy. When my son was, I think he was 6 or 7 months old, he had never like rolled over or anything like that. And I had him on a diaper changing table and looked down because one of the shoes was on the ground beside. And I went to grab the shoe, and next thing I knew, I heard like boom, and my son was actually on the ground crying, and I just felt so incredibly guilty. And you know, it's like I felt extra guilty because as an ER doctor, I see these instances so frequently, like parents coming in being like, oh, like I turned around and my child fell off the bed, and you know, like I just never expected it. And like you would think that I would know better as a physician, but parents are right. Like it happens so quickly, and it's not necessarily because they were negligent or because they were neglectful. It's just, yeah, these things happen, and it's not necessarily their fault. It's just, I don't know. It's crazy. What I'm trying to say is I can totally sympathize with the mother in this situation. Definitely brings back some bad memories for me.
O'Neal Cruz hits a walk-off tater, right? And I catch it, you know, but then somebody fell on top of me. And I think I heard a pop, but hard to tell with all the screaming.
Looks like an elbow dislocation.
Sound pretty dangerous.
You're not one of those guys who steals balls from kids, are you? Throw in an IV and start with 4 morphine.
No. I don't want to be knocked out.
We can put local anesthetic into the joint.
Just give me a bullet to bite on.
I've had this situation in the past where people have like really bad dislocations and or even fracture reductions, and they don't even want any anesthetic at all. And it's just wild to me when I'm like doing these painful procedures and they're just kind of moaning and gritting their teeth to do it. It's wild.
This is gonna hurt like hell, Roberto. 1, 2, 3.
Okay, I'm flexing at the elbow.
Okay, so this is actually not realistic. This is not how we would reduce an elbow. The most effective way to reduce an elbow is to get them lying down flat, belly down onto a bed, and have their arm dangling at that bed so that it's completely stabilized and anchored. If you have them sitting up like this and you're stabilizing the humerus like this, when you actually start to crank on the elbow, the person's going to lean over and you're going to lose all of the leverage of actually getting the elbow back in joint. So this is not the most effective way of doing it.
Yeah, I mean, you already filled in the T-sheets.
Yeah, well, I'm already here.
Yeah, I kind of had a handle.
So can you just fill out the chart?
Should probably finish it.
Well,
Okay, someone do this. I don't care who.
So childish. Usually shit rolls downhill, so if you're a junior resident, it's kind of just assumed that you're going to do the charting on a procedure. That's just how the medical hierarchies work.
I'm hoping to catch another intubation before 7. One more gets me to 3 in my first week. Probably a record.
So this is very realistic. When you're going through medical training, whether you're a medical student or a trainee, you're often preferentially signing up for the sickest possible patients because you are interested and keen to get as many medical procedures as possible. With that would include intubations. Like doing these critical procedures is not only good for your training, but it's like you want to get as much experience as possible because that gets you to the ultimate goal of being a competent physician faster. And it's often kind of like a badge of honor to your peers, you know, like telling your peers, oh, I did this procedure, whether it's like a intubation, lateral canthotomy, thoracotomy. These are all kind of badges of honors that you trainees will often like brag to other trainees. And most people would be pretty jealous and be like, oh man, like that's crazy. Like tell me more about that. Like what was it like? So this is very realistic in medical culture.
Curtis Larson, 42, called to the golf course for combative behavior with his buddies. No signs of trauma, just alcohol on the breath.
Seems to have calmed down a bit.
And he was fighting us so hard we had to give 4 milligrams of Versed to get vitals in a line. Good BP, pulse ox 99 on 2 liters.
Between the booze and the Versed, he'll be sleeping it off for a while.
Dude, what happened?
Medics had to sedate him to transport.
Could he have taken drugs?
If he did, they were not the performance-enhancing kind. He shot a 112.
This is something that we so frequently saw before COVID happened. We used to see so many people coming in from bars that were just absolutely hammered and really combative, coming from bar brawls, and they'd be incredibly rude, fighting with our staff. Oftentimes they'd be like puking in the hallways and stuff, but in the post-COVID times, like we don't see alcohol intoxication nearly as much as we used to. Most of what we're seeing are kind of street drug intoxications, like more opioids, more crystal meth, benzodiazepine intoxications. This is definitely very realistic, and most oftentimes if someone is very combative and aggressive, we treat with more benzodiazepines like Versed or midazolam, which the paramedics treated with, and then we just let them sleep it off. And usually when they wake up, they're usually quite apologetic and totally fine, and they just leave the ER.
Dr. McKay.
Yeah.
A girl named Kiki came into reception looking for you.
Kiki?
She says she'll be in the park.
Ogilvy, you want to get some air? Got a good case for you.
Might an intubation be required?
No, it's an unhoused patient I've treated on the street team. Most of these unhoused folks feel abandoned, sorry. They don't trust easily. Meeting them where they're at makes a big difference.
100%. This is so correct. There are physicians that work on the street that work with unhoused people that suffer from addiction in my city as well. It is so incredibly important to meet these patients where they're at, to just rebuild trust with them, because so oftentimes they're just disregarded by not only doctors and nurses, but just all of our societal systems, because there's so much stigma around addiction.
I've never understood drug addiction.
Well, you need to try. A little empathy goes a long way in this job.
I am empathetic. I don't understand how an intelligent person allows themselves.
Can make mistakes, heal themselves, take away the pain, hide from the abuse. We're healers, not judges.
This is such a great point that they were covering in the Pitt. So if you go on my Instagram or TikTok, I actually posted on trank dope and also, I guess, moralized care, because this is something that we so commonly see. So one of the biggest issues that we're seeing in my city is that the street drugs have been now contaminated with tranquilizers, not just xylazine, which is what McKay is talking about, but there's another tranquilizer called medetomidine, which is an animal tranquilizer that veterinarians use for animals in vet hospitals. This can often cause people to come in with a mixed picture of opioid overdose, where they're kind of slumped forward and have decreased respirations. And despite giving them multiple doses of naloxone, which is the antidote for opioids, they'll still be completely conked out and have a low heart rate, like down in the 30s, and often low blood pressure. And this means that we're having to observe them for much longer durations of time than we would otherwise have to if they just had a straight opioid overdose. When I posted this video on Instagram and TikTok, there were a flurry of comments saying these people should have to wait longer in the emergency department. We shouldn't be wasting any of our resources on people with addiction or people who used to use street drugs. And I didn't want to, but I had to post a rebuttal video talking about how bullshit this concept is. It's one of the most dangerous ideas in healthcare of moralizing care. The idea that resources should not be given to people who self-inflict injuries or self-inflict different health conditions, because when you start to moralize care, when you start to ask doctors to withhold care from people because they've self-inflicted these wounds on themselves, where do you draw the line? And who is the person that gets to decide where that line is? For example, someone who has a heart attack and led a very unhealthy lifestyle, they ate poorly, they didn't exercise, does that mean that we would push them to the back of the line? And what about someone who has lung cancer because they smoked earlier in their life? What about someone who is suffering from the complications of diabetes because they ate a very unhealthy lifestyle throughout their entire life? You know, you have to wonder where you draw that line, and that doesn't stop with addiction. Many of the people that I treat in the ER with addiction have past traumas that are just absolutely unspeakable. Like the stories that I hear from these people, it would just break your heart. Honestly, it often breaks my heart hearing these stories, like sexual abuse as children, physical and emotional abuse from their parents while they were growing up. I think it's easy for people to see someone on the street who is homeless and using drugs and just have the mentality, oh, like stop using drugs, go get a job, contribute to society. But until you've actually walked a mile in their own shoes and actually seen what kind of life they've lived, I think people should really hold their tongue and hold their judgment as well, and realize that these people are self-medicating because of their life circumstances.
So what's happening with you?
My leg's getting stinky again.
Yeah. Okay, let's take a look.
Oof, that looks bad.
Is that an injection site?
No. No, xylazine wounds can show up anywhere. You still using tranq? Nogovi, you okay?
Yes.
Yeah?
Absolutely. My plan is clean with saline, antibiotics.
It can be incredibly jarring to see leg wounds from people who have used substances for the very first time. The legs are usually very, very swollen, sometimes 3 to 4 times the size of a non-infected or non-swollen leg. And oftentimes there's these massive wounds, there's a lot of skin breakdown, and it's very malodorous. It smells really bad. And for a medical student to see this for the very first time, that is like a very common reaction for them to be like, oh, wow, like this is crazy, you know? So I work in the downtown core of Vancouver, often with people who are unhoused, who suffer from addiction. And this is an incredibly common issue that we see in the ER. Oftentimes what we'll do is we'll give them IV antibiotics that need to be administered every 24 hours. And we ask them to come back to our ER every day or go to either the wound care clinic or the infectious disease clinic every day, not only so that we can give them IV antibiotics, but it's every opportunity, every interaction with them is an opportunity to rebuild trust with them. We give them food, we give them juice, we give them clean socks, we do wound care for them. You know, oftentimes we're asking them how contemplative they are about quitting their addiction. And that gives us an opportunity to connect them with addiction specialists and possibly even get them into detox. Addiction and substance use is an incredibly complex issue, and I think maintaining a compassionate lens and treating these people with dignity is so incredibly important.
Sorry, Mr. Green, we won't forget about you. All right. You having some pain again, Mr. Green? Mr. Green?
This one's yours?
Yeah, he was just waiting on his discharge meds, pain-free.
Typically, if you do get a septic stone, they wouldn't deteriorate that quickly. Usually it deteriorates over a course of like 2-3 days. So if this is what they're painting, like urosepsis from a kidney stone, this is not actually medically accurate. They would be discharged home, and then they usually present a day or two later with fever and low blood pressure.
History of renal colic, heme positive urine, BP crashing.
Heme positive urine doesn't always mean kidney stone. Who worked up this patient?
I did. Ultrasound showed dilated ureter and mild left hydronephrosis consistent with this history of renal colic.
What about the aorta?
I didn't look at the aorta.
Who did you present to?
Dr. Mohan?
So the rest of the ultrasound was normal.
I meant that the other kidney was normal.
What he's alluding to is AAA, or an abdominal aortic aneurysm. That usually presents with abdominal pain, but the person usually has a severely high blood pressure when they present, and severe abdominal pain. If someone has severely elevated high blood pressure that is unmanaged for many years, this can cause the abdominal aorta, essentially the largest blood vessel that travels from the heart down to the abdomen, to balloon outwards. If it balloons out big enough, it can actually explode, and you can start to spill blood inside your abdomen and the retroperitoneal space, which is obviously a life-threatening condition.
8 centimeter AAA with massive free fluid. Ruptured aortic aneurysm, he's bleeding out.
Okay, who wants to intubate? Giovanni?
Sure.
Okay, call for 6 more units of whole blood. You said we'll call surgery. If we stay ahead of him, we might get him up to the OR. Here you go.
I guess like it comes back to the last review that I did, where I was saying that it was unrealistic that this guy with renal colic or a kidney stone wasn't kind of clutching his flank, probably because he didn't actually have renal colic in the first place. They're saying that he now has a ruptured AAA, or ruptured abdominal aortic aneurysm. If he's already hypotensive, the chances of survival are really, really low. So you would have to aggressively treat him with a few things. So one is tranexamic acid, which is a medication that increases blood clotting and decreases the amount of hemorrhage and exsanguination. Second thing is massive transfusion protocol, where we would just essentially just hammer the guy with packed red blood cells, pooled platelets, and fresh frozen plasma. And the last thing would be to call a vascular surgeon to get him up to the operating room as quickly as possible so that they could do a repair of the ruptured AAA.
6/52.
Some progress. About 2 grams TXA?
Yeah. What else do we give after?
TXA is tranexamic acid, what I mentioned earlier. Ogilvy is choking under the pressure, and obviously he's ruminating over his misdiagnosis. Everything that they're doing is actually medically appropriate. This is all very realistic.
Should somebody place a central line?
Long central line is slower than short, large bore peripheral.
Flow is proportional to the 4th power of the radius.
Yeah.
Physics.
This is something that we talk about very frequently. Novice medical providers, like medical students and residents, automatically assume that inserting a central line is like the quickest way to deliver high amounts of blood product or fluids for fluid resuscitation. But actually 2 large bore IVs, whether it's a 16 gauge or an 18 gauge, can actually deliver much higher volumes of fluid because they're shorter length IV fluids and they're quite large bore. So this goes back to basic physics, what we refer to as Posse's law, where the flow is determined by the diameter of the tube and inversely related to the length of the tube.
Systolics down to 68.
Units 5 and 6 are up and running. I'm here for Garcia. Vascular can't come down.
AAA with hemorrhagic shock.
Most of these die in the field. Prep for a thoracotomy.
Dr. Giovanni, why don't you glove up and show Dr. Shamsi why you belong in the ED?
Damn.
There's no blood in the chest, it's all in the belly. Yeah, keep squeezing.
Heart is empty.
Okay, Giovanni, get in there. Internal compressions, go. Let's put 2 more units on the rapid diffuser, please.
They'll be units 7 and 8.
Essentially, the rupture happens below the level of the diaphragm. So if someone is in cardiac arrest, essentially if someone is dead because they're bleeding out from ruptured AAA, the acute management would be to actually open up the chest with a thoracotomy so that you can cross-clamp the aorta. Okay, so again, like the aorta is the biggest vessel that comes off the heart and down through the chest and into the abdomen. So by cutting open the chest, we would actually be able to find the aorta and clamp it off so that you stop bleeding below that level. And by doing that, you would actually be able to refill the tank by transfusing the patient with blood products and perfuse your vital organs like your heart and your lungs and your brain. Looks pretty realistic. I've assisted in 4 thoracotomies throughout my career, and every single one of them is incredibly dramatic, and it's usually heroic measures, but the chance of survival if you're actually doing a thoracotomy are incredibly low.
I'm really sorry, Dr. Robbie. I should have checked the aorta.
It's an easy one to miss. Got a heartbeat back though, so.
Okay, blame actually isn't on Ogilvy in this case, it's on Samira for missing that diagnosis, because you can't fully rely on a medical student to rule in and rule out the life-threatening diagnoses unless you have actually gone through all of the information yourself. So it would have been on Samira to actually ask pertinent questions to make sure that she wasn't missing that AAA. So yeah, I'm curious to see if Dr. Robbie reams Samira out for that.
It's my fault.
It is. You're the senior resident. You don't look to others, others look to you.
I know, I'm really sorry.
This is what happens when you bring your personal life into work. Patient almost died.
I know.
You have to think of these walls like a force field. You cannot let anything in. That is the difference between the best doctors and the ones that don't make it.
Damn. I mean, Dr. Robbie brings up a lot of good points that, like, yeah, you want to leave your personal baggage at home. You don't want to bring that into the ER. You don't want that to negatively impact your interactions or your clinical judgment on the patients that you're actually treating yourself. Everyone does have bad days though. And I think a little bit of compassion on Dr. Robbie's part would go a long way. People make mistakes, people misdiagnoses. Not every patient survives. And to just like completely destroy a learner's confidence because of one bad outcome is just not what a good attending would do.
ICE is in the building.
Word travels fast. Yeah, we have a detainee with a rotator cuff tear.
2 of our nurses went home. They have temporary protected status, but they just don't feel safe.
Está pasando atrás, amiga. Aquí está buscando a alguien.
No sé.
Can't we just tell the agents to fuck off?
Yeah.
They are not going to leave without their patient. We just need to treat her.
Even if she's undocumented?
All patients, regardless of immigration status, have the right to emergency care under EMTALA.
Yeah.
She took a nasty fall, her shoulder, screamed in pain when we put the ties on.
Hello, I'm Dr. Rabinovich. This is Dr. McKay.
Agents Correa and Russo. She needs to be looked at before we process her.
What's your name, ma'am? Renita.
We're gonna take care of you, okay?
You said she fell?
We're conducting a sweep at a restaurant. Hey, when the kitchen took off, she was shoved down some alley stairs.
Right. I do not want these guys here any longer than they need to be, so let's find X-ray and fast-track this one.
Wow, this is getting pretty crazy. God damn. Okay, so they just have ICE agents bringing in a patient of color after she was shoved down some stairs. And this is becoming a more and more prominent issue in the current political climate and in emergency medicine. So I recently went to a medical conference where one of my colleagues, who's an emergency physician from LA County Hospital, presented showing year-over-year statistics from his hospital showing that in the last 6 months, the ED visits, the emergency department visits, dropped 30% year over year. And when he actually speaks with patients, he says that the patients tell him that they're so afraid of coming into the ER because they're afraid that if they come for medical help, ICE agents are actually going to meet them there and deport them back to their home country. And this is a major issue because so many of the patients that he is actually seeing are holding off until the last minute to actually seek medical care for serious medical issues. And this has led to many of them getting too far gone with their medical conditions, like whether it's a heart attack or a stroke or sepsis. And a lot of them are suffering from increased morbidity and mortality. Essentially, they're too far gone and they can't save them. This raises a major question of whether it's moral or ethical for federal agents or governments to actually come into hospitals, which are essentially be places of sanctuary, should be places where patients can come and feel safe and trust that no other issues are going to happen except for the medical care that we're providing to them. I think that this is one of the biggest modern day tragedies.
Can you lift your right arm up above your shoulder like this?
Positive drop arm test.
What's that mean?
That means that she's going to require an x-ray. It's most likely a rotator cuff tear, which sometimes can come with a fracture. We need an x-ray to rule it out.
How long is that going to take?
I'm trying to think of like what I would do in this scenario, because my job as a physician is to advocate for the patient, for their safety, for their well-being. I wouldn't know all of the context, and I think I would just feel powerless, like in the presence of a federal officer or an ICE agent. Emergency medicine is such a challenging job at its baseline, but to introduce this kind of bullshit into our ERs where, government agents are coming in and, like trying to arrest patients, I think that would be so incredibly demoralizing and difficult to deal with.
She doesn't know what I am. I just wanted to know that I'm okay.
Yeah.
You seriously won't let her make a phone call?
Not until she's processed.
Unbelievable. No fracture.
Okay, we'll just have Jessie fit her for a sling, I guess, and then we have to discharge her.
To the immigration guys?
I'm afraid so. Patients come in here for help, right? Because they're either sick or they're injured, and documented or undocumented, they have a right to emergency care. TB, measles, fractures, none of it's getting treated because everybody's too scared to come in. But then they end up here anyway, but then it's too late. So please, for the love of God, can you just go wait over there in the room with your detainees so I don't lose any more patients or staff?
No problem, Doc.
Good for Dr. Robbie.
Pittsburgh.
No. I would be so pissed. I feel like I'd have to really resist the temptation to just tell him to
Pittsburgh.
Hold on, she needs to slam.
This will only take a minute.
We're leaving.
Hey, man, you're hurting her. Jesus Christ, what's going on now?
Robbie?
Get your hands up.
Hurt her and Jessie stepped in.
Oh, yeah, I didn't do shit. I know.
No.
You don't have to say anything. They can't make you say anything. We'll get you an attorney. I promise we'll get you out. What happened? But please, everybody get back to work.
Holy shit.
Who's gonna take Jessie's patient?
I can do it, Dee.
Thanks, Perla.
Damn, dude. This show just escalated like crazy fast. Oh man, what just happened? Holy crap. The woman being detained, but to also have to manage the ICE agents who took away Jessie, the nurse, as well as all the drama within the emergency department. I think that would be incredibly difficult to manage as the attending that's kind of most responsible in that department. Crazy.
I have faced my fair share of punishment for what I did.
You stole drugs from the hospital. I should have reported you to the state medical board. You should have lost your license and gone to prison.
You don't know what I've been through.
What you've been through?
My wife threatened to divorce me, okay? I almost lost my kid.
Yeah, that's what happens when you fuck up.
God damn, dude.
Tell everyone here you stole drugs and got kicked out of the ED because of it. Until then, stay out of my way.
Bro. Wow. That is crazy. I'm all for holding people accountable for wrongdoing, but to ream someone out like that in the middle of the ER and to have absolutely no empathy or compassion or belief that someone can redeem themselves after bad choices, I don't know, that seems too harsh. And I think the other thing that people don't understand is when someone is addicted to substances, addicted to drugs, a lot of the decisions that they make are driven by that addiction. Essentially, they're doing anything and everything possible to get their next fix or to prevent them from going to withdrawal. And sometimes that does lead to people stealing drugs from workplaces like the hospital. I've seen this in my career when I was in residency. There was a nurse that was doing this as well, stealing morphine that was like being discarded into the waste bins. You know, she ended up dying from that. I don't know. It's just, yeah. It's really important for people to remember that addiction is it's a disease. Addiction is a disease. It's a mental illness. And yes, accountability matters, but also compassion matters as well, knowing that people can redeem themselves and come back from something like that.
Oh, hi.
Pittsburgh.
I'm just checking your vital sign. Oh.
Where am I? Guys, what did you do to me?
Bro. Oh God, dude. Oh my God. Dude, this episode was so intense. Oh my God. What the hell happened? That was really, really intense. There were just so many different aspects that they covered in this episode. I'm really curious to see what happens in the next episode. It seems like the season is kind of like climaxing right now. If you found this review entertaining, educational, or insightful, please support this channel by liking the video, leaving a comment, and I'll see you guys in the next one.